Hey everyone, this is Dr. Koenig, and this week we are going to talk about assessing for lethality. Let me make this big here so that it's more easily seen. I wanted just to talk a little bit about growing as assessors because assessment is one of the most complex tasks that we can do as counselors or clinicians. It involves a lot of critical thinking. We have to be mentally flexible. We have to have a broad knowledge of theory. We have to be able to have insight into behavior and the motivation behind behaviors. Hopefully, you're gaining skills in that as you go through your master's program. We also have to be skilled using several instruments, a cross section of different instruments in different areas. We have to be able to conceptualize cases. We have to be able to know some basic research, hypothesis making, scoring instruments, understanding the instrument, and being able to explain the results of an instrument. And we have to be able to understand that in terms of research, those things we learned about the curve and about percentiles and rank, and be able to put that in language that is going to be understood by the general public and layperson. We have to have some pretty good diagnostic skills, and we have to have knowledge of interventions in order to be able to match whatever diagnosis we assign with interventions that we might recommend. So, understand that this is your second class in assessment. You're still growing. We don't expect you to be accomplished experts at this point in time, and that through the process of growing expertise in this area, you're going to get stretched a little bit. So I threw this in here because I want you to understand that as we're talking about assessment, assessment really is sort of the pinnacle on the taxonomy here. So the first thing we do when we're learning something is we just remember, we recall facts. It's sort of just regurgitating things. We begin to understand. Hopefully we apply, and you're in the application of things now because you're all in internship. You're applying concepts, you're solving problems, you're interpreting things, demonstrating your knowledge of it. You hopefully are also analyzing, and you're able to compare, you're able to distinguish when something is pathological or when it's not, hopefully. You're able to test when you have a theory. And then we're getting up toward the top of the triangle here, or the pyramid. We then begin to evaluate, and all of the skills that are below evaluation, we should have pretty good mastery of when we begin evaluation. So, evaluation and assessment is the synonymous, same thing. And then, as part of assessment, we're going to create something. We're going to produce a new or original work that is an assessment of the individual. So, understand that the ability to gather information, to synthesize, integrate that information, to understand human motivation, and have insight into behavior from a theoretical or case conceptualization standpoint is all one part of doing an assessment. Being able then to put that into words, into written words, or to verbally explain that in plain language to a client, but also to put it in a written report that is understandable for those who are asking for the referral or asking for the report. It does take some skill. So, this will give you, hopefully, this class will give you some practice in being able to do that. So, with that being said, sometimes there's a lot of detail that goes into constructing the evaluation and the report. So, to make that a little more simple, I wanted to talk about interview assessments because it helps me if I have a framework in mind, something that's a little bit less complicated and something that I can remember in my head that I can refer back to. So when it comes to assessment with lethality or suicide assessment, in particular, what we're going to talk about in this lecture, um, these are the things that have been helpful to me, and I think that they're commonly used. So you'll see PIMP. I use a PIMP because I know that drugs and alcohol are something that can be very critical when it comes to assessment for suicidality. So a PIMP adds in the alcohol and other drugs. Then there's also the acronym is Pathworm that can be used, and Simple Steps. Simple Steps is not, I don't think, easily available at this point. So I have a slide in here on Simple Steps because it's what we use where I work. So this gives you just the broad overview of what Simple Steps is if you're interested in this. And I have it in here again as well. I think the other two, APIMP or PIMP and Is Path Warm, are available online or publicly available if you do a search. Okay, so I'm going to draw a lot on the Suicide Prevention Resource Center, their Education Development Center. And you can see down in the lower right hand corner, that's where my citation is from. So I have attended their training a couple of times. I highly recommend it for anyone who does a lot of assessment of suicide risk. I work in a college counseling center, and suicide assessment is our bread and butter. We are assessing for suicide every day. Sometimes it's very serious suicide risk assessment. Sometimes it's um, lower risk, but it's day in and day out. We're assessing for suicide. So it was important to me to become very competent and skilled in suicide assessment, and to be able to feel feel very comfortable with that. So I'm going to draw on that training. I'm also going to draw on the author of Simple Steps and a training that he did for us. His name is Jason McLaughlin, and I have his citation in here as well. And he's also in the reference at the end. So if you have an interest in finding out more about Simple Steps, I'm sure there's some publications out now. Okay, so competencies, as you can see here, these are the competencies that's identified by Spark. You'll notice that on the list, I've got some in bold. The ones that are in bold, I think, are particularly of interest in assessment. If we are talking from a clinical sense, I am assessing because I have this person in therapy, I'm responsible for them on an ongoing basis because I am their therapist, then everything on this list is going to be 100% applicable to me all the time. If I am seeing somebody because I'm just performing an evaluation, they've been referred, and that's all that I'm doing, then the things in bold are going to be the most pertinent to me. It doesn't mean that the other things aren't pertinent. It just means that where I live and breathe for assessment is going to be where the bold things are. And I'm going to focus on those primarily because this is an assessment class. Okay, so attitude and approach, yes, it's important. We want to make sure that we're managing the counselor, our own reactions when someone starts talking about suicidality. Sometimes there's going to be differences between the client's goals and the counselor's goals because the client's goal may be to escape the pain that they're in by whatever means they can do that the quickest. And sometimes that means if I kill myself, I don't have to feel like this anymore. So the client may have that goal in mind. The counselor's goal may be not to see the person kill themselves. So obviously, there is a difference between the counselor's goal and the um, client's goal in that situation. And we have to be able to reconcile that to understand that it's there and to work within that framework. We have to do that while we maintain this collaborative stance with our client. So if you're not seeing somebody, particularly because of suicidality, this may not be, it's important, but it may not be sort of um, quite as important as if you're seeing somebody simply because they need to be assessed for suicidality. So, understanding suicide, if you're doing a general assessment, say you've got somebody who you're assessing because they, need um, a recommendation about custody, or it's a school referral for intelligence or something like that, you're still going to do that mental status exam. You're going to touch on suicidality, and you never know what you're going to find. So you have to be prepared to do a full suicide assessment if the person indicates that, yeah, they have been thinking of suicide. And then you're going to have to flesh that out and see what the parameters are. Do they have a plan? Do they have intent? So forth and so on. So, in understanding suicide, we need to understand the phenomenology of it, what the risk factors are, and what the protective factors are. And that right there could be an entire class. So I will just say this is important, and we need to make sure that we understand it. We need to make sure that we are collecting accurate information. So risk assessment, if we're in a clinical situation where this is our client on an ongoing basis, then risk assessment needs to be integrated early in our clinical interview process. So from the word go, our first contact with a client, we need to be assessing for risk. If we're seeing this client on an ongoing basis, then we're going to do risk assessment on an ongoing basis. If it is a referral and we're seeing this person for some other type of assessment battery, we're still going to do risk assessment. And we're going to attain collateral information in either one of those situations as is appropriate. So I think this is probably the biggest challenge in assessing for suicide is how do we get accurate information? And there are some techniques that we use to try to get accurate information. I'm going to actually upload a little cheat sheet. Well, I don't know if it's a cheat sheet. It gives you some information on each one of these, it defines them. Um, Normalizing, shame attenuation, behavioral, talking about behavioral incidents, making gentle assumptions, denial of the specific. If we're assessing an adult, you don't want to use denial of the specific if we are assessing a child, and then symptom amplification. All of these techniques are great ways to put a client at ease, to make it okay to talk about suicidality, to talk about thoughts of killing oneself, and to do that in such a way that it's matter of fact, that there's not, it's not criminalized. We're not making the person feel like a criminal, or we're not making them ashamed for having those thoughts, but we're just being very matter of fact and compassionate in the way that we're approaching it. So I will upload those definitions so that you can take a look at those. What information we want to gather. We want to talk about long-term risk factors. We want to assess for impulsivity, because the more impulsivity a person has, then in general, the higher their risk would be, or the more at risk they would be for suicide completion. We want to assess for past behavior, because the best predictor of what's future behavior is past behavior. So we want to know what that was. We want to know any recent or present suicidal ideation or behavior. We want to know what stressors the person is under right now, or what stressors they anticipate they're going to be under in the very near future. The next 72 hours is generally what we like to look at whenever we're assessing for suicidality. And that differs a little bit by state. Some places it's not codified, but we really, really want to be able to look at the next 72 hours. We want to look at those dynamic factors, those things that are changing or expected to change in the very near future. How engaged the person is, and how reliable the information that they are giving us is, whether that is our client or whether that is a collateral source. After we have gathered our information, then we're going to have to formulate our risk. Understand that there is no such thing as an assessment we can give an individual that's going to give us a score that tells us if this person is going to complete suicide in the near future or not. It comes down to clinical judgment, and clinical judgment should be based on a very thorough and accurate collection of information from the client and from all the collateral sources that we can get information from. Now, that being said, sometimes we don't have every bit of information, and we still have to formulate an idea of a risk and make a clinical judgment. So, we want to do that. We want to integrate and prioritize all of our information that we've got. We want to think about the client's motivation to minimize their risk or augment their risk. And some clients will be very motivated. They're scared by the fact that they're suicidal, or they're scared by the fact that they're having these thoughts. Other clients will present in such a way that they're not necessarily scared that they're thinking about suicide. They may actually seem disappointed that their suicide attempt was not successful, in which case that's much higher risk. We want to consider or assess the imminence of suicidality. How far in the future are we predicting, or are we thinking that this person may act on their plan or their thoughts, or develop strong, very strong intent? We want to assess for chronic suicidality, because there are folks who are chronically suicidal, who never make a suicide attempt, but they deal with chronic suicidality all of the time. We want to consider the person's development, their age, their emotional development, their culture, and gender related issues. I would also say culture includes religion, and the influence of religion on suicidality or acceptance of suicidality, or suicide completion. We want to document both our judgment and how we got there. So, whatever the rationale is for the judgment that we assign as far as risk goes, we want to make sure that we are clearly documenting that, and we want to document it in a timely manner. So, this is from Spark, and this is how Spark recommends that we come up with our information and formulate our risk. So you can see here on the left side all of the different factors that we would need to review from our interview and from our data collection from the individual, how those things get put together to arrive at a risk formulation. And then if you can hold simple steps, if you can hold this in your head, if you're doing an interview or you're having a conversation with someone, you can mentally check this off in your head, or you can use one of the other models as well. But I can use this as a mental sort of checklist for myself to make sure that I'm hitting everything that I need to hit on, and I can go as deep as I need to go. If the person is answering with questions that indicate a need for further assessment, then I'm going to keep going and keep going until I have sort of saturated every bit of information that I can from that particular category. And then move to the next. And I say that as though I'm doing that in a structured interview, which it can be, but it can also be in a conversation where you're filling in the parts of the assessment model as you have the conversation with the client, maybe sort of leading the direction of how the conversation goes with some direction maybe, or some questions or some probing from you at times, depending on what information you need more specifics on, or you need more details on. Okay, so the clinical judgment of risk, it integrates all of these things that I touched on earlier: biological, cultural, social, family, SES, psychological characteristics, all of those things. One of the things that's very important when it comes to assessing for suicidality is looking for discrepancies. There are times when a person will deny that they are having thoughts of suicide, but we got the referral because they told someone, or they put it on Facebook, or otherwise posted it on their social media, that they were, thinking about killing themselves, or they were not going to be here much longer, or something like that. So if there is a discrepancy between what the person is saying to you, the way they're presenting to you, our assessment of their of their depressive symptomology, their acute risk factors, or their mental status, or their behavior, discrepancies need to be followed up on, and we need to figure out exactly what we think is going on. If there's a discrepancy between what the person is telling you and the way that the person is behaving, we always lean toward the behavior, because the behavior is going to indicate more firmly to us and more accurately to us where the person actually is. When it comes to adolescents, if we're assessing them, try always to get information from multiple sources. So we really need those collateral sources, whether it's parents and guardian, foster mom, teachers, principal, coaches, whether it's someone from church, whether it is a scout leader, it's whoever the person is close to. We need to get information from them, because it's very difficult to assess lethality on an adolescent just based on what the adolescent is telling us, and to do that reliably. We want to know the risk factors, the protective factors, and what the current research is saying about suicide. We also have to go into this knowing that there's no such thing as a crystal ball. We don't have one. There's no way to know for sure. It is a clinical judgment, and we want to make sure that we are being thorough. We want to be thorough with our conversation, our clinical interview. We want to be thorough in any thing that we're asking our client to fill out. We want to be thorough in getting collateral information, in taking our time and looking it over, in consulting with a colleague if need be, and then in making that clinical judgment and documenting it. So I'm going to use here the risk levels that are used by Spark. Risk levels, you will hear a lot of different terminology. Um, Pick something and stick with it. So you should be consistent. Your agency or your organization should be consistent. If you are working for an agency that uses a particular um, uh, terminology and risk level, use that risk um, terminology in your assessment when you are working at that agency. Make sure that you understand it thoroughly, because for consistency's sake, everybody in the same agency should be using the same terminology. So for this assessment, or for this lecture, we're going to be using the SPARK terminology. And SPARK says there's high acute risk. You might hear this called high risk. High acute risk, a person recently engaged in something that was potentially lethal with the intent to hurt themselves or kill themselves. And they have made preparations. They're experiencing persistent thoughts and they have a strong intent or plan. I always try to scale intent. So I'm going to ask the person on a scale of 0 to 100 or 0 to 10. You can scale it however you like or however your agency does. But I always have the person give me their intent on a scale, because if I'm seeing them on an ongoing basis, I'm going to want to ask them that question more than one time. So next week, I want to know what their intent is. If it's they're giving me a number, then I'm going to be able to very quickly to see if their intent is going up or down. If we're talking about imminent risk, and you hear imminent risk a lot, imminent risk is the medical term. It is interchangeable with high acute risk. Anyone who is at high acute risk or imminent risk, we're going to be needing to take action to keep that person safe, and we are going to do that immediately. There's also moderate acute risk. This is a person who may have suicidal thoughts, but they don't have a plan and they don't have intent. Or I'm sorry, they do have a plan, suicidal thoughts with a plan, but they don't have any intent to act on that plan or on those thoughts. Then we have low acute risk. This is a person who has thoughts of death. That might be something that occurs frequently. It might be on a daily basis. It might be several times throughout the day. This person generally is not going to have a specific plan. They might not have intent, and they're not going to have behavior. Keep in mind that all acute risk is fluid. It goes up, it goes down, and it follows intent. So as intent goes up, acute risk goes up. Acute risk is generally time limited because it is more of a crisis situation, and we are not folks who can maintain a crisis state on a long-term basis. Now, on the other side of that coin is chronic risk, because we have folks who do have chronic risk. They have chronic risk factors and they might think about suicide a lot. They might be at low acute risk, but they might also have chronic risk because those thoughts may be periodic. They may be ongoing at a low level or in frequency, but then have periods where the level of frequency is more often. Okay, so what we need to consider, and there's a lot that we need to consider. So you might want to pause here and come back to this if you need to sort of process what we've talked about so far. The next 3 slides, there's a lot of information. If you need to sort of go back to that big picture with simple steps, this is where we're sort of diving down into each area. So keep the big picture in mind, and then understand that this is just sort of down to the granular level under one or more of those terms of the model. So suicidality, we want to know suicidality past and present. What's their history of suicidality? The best predictor, future behavior is past behavior. I already said that, but it always remains true. And I've put in here just some sort of formulation. So if the person has a history of attempt or attempts, they have suicidal ideation or plans, and they have intent, then they're probably going to be high acute risk. And you notice I say probably, because you do need to take in consideration all factors. But if you have all of those things, I think it would be difficult to make an argument for anything less than high acute risk. If the person has a history of multiple attempts and there are other significant risks, then they're at least going to be moderate acute. They could be higher. So let's also consider mental disorders. Well, let me back up for a minute. When we're talking about suicidality and we're assessing in this area, we need to actually get the details of any time that the person considered suicide in the past, what they considered doing, if they made any attempt, any took any action, even if they abandoned that action, we want to know what it was that they did. We want to know if it was they figured out where dad was keeping the gun. We want to know if they actually, went and got a rope or figured out if the, light fixture in their bedroom would hold their weight, or, what action did they take, even if they abandoned the action. If they've made multiple actions at different times, then we want to make note of that. If there were different means that were considered, we want to make note of that. We want to know if they still have access to those means. And we'll talk about means here in a little bit. But this is all about history of suicidality. How often do they think about it? Have they thought about it before? And all of those things that I just said. So then we're going to move to, what is their psychiatric history? Do they have right now notable symptoms of depression? If they have notable symptoms of depression, they have a resolved plan, and they've made some preparation, they are at minimum, well, that's probably not a good way to say it, but the least they're going to be is moderate acute risk. They may be high acute risk. If the person is suffering from command hallucinations, that's the person is hearing a voice that is telling them that they need to kill themselves, then that really drives the risk up. We also sometimes deal with folks who are having command hallucinations for homicide. We want to check that out while we're visiting sort of this area. Any voice telling them to do anything, whether it's harm another person, kill another person, harm themselves, kill themselves, we want to know about that. If they have a psychiatric diagnosis and their symptoms are severe, or there is some type of acute precipitating event, then more than likely they're going to be at high acute risk. If the person has a psychiatric diagnosis and severe symptoms or an acute precipitating event, those protective factors that can sometimes be helpful and mitigate risk are not going to be relevant in this particular situation. We're also going to consider mental status. So every time we are doing an assessment battery, we're going to do a mental status exam. We're going to start probably with a brief mental status exam, and then as the person gives us answers, we'll know in which areas we need to dig deeper. So you can see here that I've put in some possible formulas. So the person is highly distressed and they have a history of multiple attempts. We're going to be really concerned about that person. So at a minimum, they're going to be moderate risk or high risk. If they have plans, they've made some preparation, and they have significant intent. And in my world, significant intent would be in 6.5, 7, we're getting significant. Then I'm going to probably assign them high acute risk. Another thing that drives up risk is sleep disturbance if the person is getting poor sleep and they're agitated. So if we're agitated, we're not sleeping, risk goes up. If the person expresses hatred for themselves, if they really have an inability or a constricted ability to problem solve, they really can't see any solution. There is no solution to whatever is happening right now, or there is no solution to the way that they feel. So hopeless, they're hopeless, and the future is hopeless. There's no way to fix the problem. There's nothing they can do. The the more constricted they are in their ability to problem solve, the higher risk they are. If the person has a history of aggression, if it's aggression toward others or aggression towards self, then that's going to drive risk up. We want to consider impulsivity because the more impulsive a person is, then the more at risk they're likely to be. We want to assess for means. What means, if any, has the person identified? If they do have an identified means or more than one identified means, we want to assess each of the identified means. Is it accessible to this person? If it is not accessible, what would it take to make it accessible? Because they might not have a gun, but they might be able to borrow one from dad on the way home from your session, or the neighbor, or someone else. Is the means lethal or potentially lethal? I one time was doing a suicide assessment with a young person, and they had a lot of intent that they were expressing. Really, really wanted to die. Their method was they were going to try to lock themselves inside of a Tupperware container. And they had the Tupperware container, and they were able to show me the Tupperware container, which their head would not fit in. Um, Now, that doesn't mean they couldn't figure out another way, but the means that was accessible to them that they had identified and planned on using would not have been lethal. Then we also need to evaluate for stressors, and those are those dynamic factors. What is changing or expected to change? Um, Men, especially, some of the completed suicides that I have either have occurred in agencies where I've worked in the past. For men, normally, a high percentage of the time, there has been the breakup of a relationship and the introduction of alcohol. So we know that when men are at greater risk when a relationship ends, we know it's a research finding. We know that across the board. I can say to you that I have seen that in my experience be borne out um, in reality on a day-to-day basis. Perturbation is something we also want to consider, and perturbation is just a fancy way of saying emotional pain. I will also scale this and say, what is your emotional pain that you're experiencing right now on a scale of 0 to 100, with 100 being the most emotional pain you've ever been in your life? What number would you put it at right now? So I want them to give me that number. And then I also want them to tell me what would move your emotional perturbation or your emotional pain up. If it is my wife staying gone, if it is, my father passing away from COVID, if it is, whatever it is the person identifies, I want to know how likely that is to happen. If it's likely to happen, is it likely to happen in the next 72 hours? So I'm going back to those dynamic factors. What's it look like on emotional pain? What's it look like now? What do we anticipate it's going to look like in the very near future? I want to know if this person uses substances, if they are substance dependent, especially alcohol, because there is a proven connection between alcohol use, depression, and a history of aggression, especially in men, and completed suicide. So alcohol, we all know, I think, is a disinhibitor. So one of the things that we will want to do if we're assessing somebody who is at higher risk and they do use substances, we want to try to see if we can get them to agree to a period of time where they will abstain from substance use. If we can, that we have effectively reduced risk for as long as that person will remain abstinent. Okay, so we want to consider suicidal thinking. Suicidal thinking, it's always clinically noteworthy. However, if the person has no plan, they've not made any preparations, and they have no intent or history of attempts, then in general, they're going to be low risk. I said in general because we do still need to be thorough in our assessment. So we need to make sure that there's no plan, preparation, intent, or history of attempts. So be sure to assess all domains. You also want to make a note of suicidal ideation because the thoughts are there. So we do want to note that. Discrepancies, let's go back to those for a minute. We really want to consider discrepancies between statements and behaviors. So, preparation and rehearsal, those are actions, those are objective behaviors, and that is evidence of intent, even if the person with their words is telling you that they have no intent of completing suicide or they're not thinking about suicide. If they're also telling you they've made preparation or they've engaged in rehearsal, then that information is in direct opposition to what they're telling you in words. And we're going to go with the objective evidence of behavior. If objective evidence is provided, in other words, the person is telling you, yes, they've engaged in preparation rehearsal, then effectively that client is already acting on their plan. So we're not going to, even though they might say, no, I'm not thinking about that, the more accurate information is coming from behavior. So, high acute risk is related to active intent. It doesn't matter whether the person is telling you, I feel really suicidal. I really don't think I can trust myself to be safe because I really would like to end this pain. So if they're telling you that, they're going to be at high risk. If they're telling you, no, I'm not at risk, but their behavior is being reported as rehearsal and preparation, they're still at high risk because they have active intent. Okay, so if you're assessing for acute risk, I think I've said this before, risk factors are only important in the context of active suicidality. So when you're assessing for chronic risk factors are always considered. My phone is ringing. I'm trying to turn that off. Okay, sorry about that. Okay, we're also going to consider homicide assessment if appropriate. If we are dealing with a postpartum woman, we always want to touch on homicide assessment because of postpartum depression and other issues. If we are dealing with a male who has some type of personality or characterological disorder or is paranoid, if that person has a situation where they're dealing with a loss or some type of humiliation, public humiliation is awful, we want to assess for homicide as well. And homicide assessment can run parallel as far as like the means and methodology for assessing homicide can run very parallel to suicide assessment in many cases. If we're doing a forensic assessment, I'll talk about that a little bit later because the court is wanting us to do something that's a little bit different. But if we're assessing with for, based on a clinical presentation and the person is answering yes to some of these questions, we're going to go ahead and assess for homicide and use a very similar structure and very similar questions that we're using for suicide assessment. We definitely want to find out if the person has an identified potential victim, if we know that victim's location, as much preparation or plan or intent as anyone has whenever they are discussing possible homicide. Or not just homicide, I guess, but also intent of serious bodily harm. So then there are some other factors that we need to consider. We need to consider how reliable the information is that we're being given. That applies to our client and that applies to collateral information. We need to evaluate our therapeutic relationship. Even the strongest therapeutic relationship is not sufficient to prevent an attempt if a person is experiencing a lot of emotional pain or they have very high intent. So do not feel like this is a failure on your part as a clinician. The therapeutic relationship cannot overcome in 60 minutes or 90 minutes or 120 minutes what is going on in the person's life the other 23 or 22 hours of the day. Transitions. Consider the transitions in a person's life, and especially discharge from inpatient treatment, because a person is known to be more at risk after discharge, immediately after discharge. And then we also want to consider protective factors, but those are only relevant in the context of active suicidality. Okay. And then we want to, if we're doing an assessment, we might want to, I use this develop a service plan terminology, but what we're really doing is we're really developing treatment recommendations. So if we're doing this and the person is not at high acute risk, they might be at moderate risk, they might be at low risk, we still are going to make some treatment recommendations. We might want to identify a range of treatment alternatives and put that in our assessment report. If we're doing, if we're touching on suicidality as part of a larger battery, because it's not the focus of why the person was referred, but the person was referred for some other reason. But we get into lethality assessment and we discover the person is at high acute risk. Then basically our assessment of everything else stops. And we're going to do a very thorough assessment of lethality. And we're probably going to end up having to act to keep this person safe, which means our assessment for all the other issues is going to have to be put on hold. And then we're going to develop an immediate service plan to keep this person safe, whether that is taking them to the hospital, admitting them to a hospital, getting them other help that is immediate. And then once once the person has been handed off to someone who can deal with their immediate high acute suicidality, then we're going to go back and do what we need to do as far as our documentation, and we'll pick up with assessment when the person is in a more stable place as far as lethality goes. So if we have this person in therapy, because I think that this probably will happen at some point in time. So even though this is an assessment class, I also want you to understand that if you are seeing this person as a part of therapy, then you're not going to be able to pass them off to someone else necessarily. Then it does become about developing a service plan, developing treatment, and then following through on that treatment. So, as part of that, you would engage in a crisis response plan, or people call it different things. In our agency, we call it a crisis response plan, but it's basically a plan that is going to reduce the risk factors wherever possible. So if someone is triggered by, they're a vet and they go to the 4th of July and it reminds them of explosions in Afghanistan, and that reminds them of seeing their friends blown up, then we're going to avoid 4th of July celebrations. We're going to plan something else. So we're going to reduce risk factors. Whatever those risk factors are in this individual situation, you're going to address those. We're going to increase the protective factors. Wherever we can increase those, we're going to do that. We're going to mobilize the person's support system. Every person's support system is going to look a little bit different, but we're going to take into account what that is. And there should be folks who are in the person's life, whether it's agencies, whether it is case management, whether it is spouse, whether it's sibling, roommate, whoever it is that's close to this person, that can be part of their support system whenever they are in crisis or feel their risk level or intent going up. So they can reach out to this person, and this person also has an idea of what's on their crisis response plan and what to do if the person has done all of the steps on the crisis response plan and they are still in crisis. Then what are the next steps? And there should be several levels of that. Okay, so then managed care, and managed care is usually what we do as a clinician, not an assessor. So if we're doing managed care as an assessment, it's probably because the person was imminently or acutely suicidal whenever we were in that phase of our assessment. We've had to stop what we're doing, and we have basically had to make sure that we have done a thorough assessment just of suicidality. To do that, we drop back to a problem solving approach. We're going to adopt a very matter of fact demeanor, which is probably what we have in assessment anyway, so that works well. For ourselves, we need to keep in mind that yes, this person may be in crisis, but crisis is an opportunity for growth. They might not feel like that. We're not going to say that to them necessarily, but we know that. Understand that crisis is generally short lived. We're not going to punish the person for being suicidal or for having suicidal thoughts or for sharing information about the deep, dark thoughts that they have. Because if we act in a way that is punishing to them, they're going to clam up and not tell us anything. And we will not be able to actually do a good assessment. We also don't want to reinforce suicidal behaviors. So, this very matter of fact, it is, this is where we're at type of attitude. That's what we want to adopt. We want to be compassionate and we want to be professional in our approach. So, if this is where we have landed, then we're going to link that person to care, and then we're going to make recommendations for care as appropriate when we do our assessment and our written report. At some point, we're going to need to communicate the test results. Now, if we are in the middle of a test battery and we're doing lethality assessment and find that this person's at high acute risk, then we're going to need to have this discussion of suicidal risk in plain language right then, because we're going to need to get that person to safety or link them to immediate care. So we're going to have this discussion about, here's where I see risk, and we're going to talk with them through the different areas that we have assessed risk in. And we're then also going to talk to them about what needs to happen next. And what needs to happen next is further evaluation, a trip to the hospital. Um, Maybe we may end up having a trusted person come and transport them to the hospital. If you're in a hospital when you're doing this, it might be, walking them over to another part of the hospital, whether that's the emergency room, which is generally where things like this are um, initially dealt with, or something else. It may be making arrangements for transportation, or it could, be calling their physician who or psychiatrist who's dealing with this on an ongoing basis, and then the psychiatrist will make arrangements for them to be admitted. It really depends on the individual circumstances, but what we have to be firm about is that this is the steps that needs to happen next, whatever the step is that's going to keep this person safe in your clinical opinion. And that may be something that is difficult for the client to hear, and it may be something that they don't want to hear and they really don't want to have happen. So we have to be very compassionate in the way that we are having that discussion with them. If we can put this in terms of, we all want what is best for the client. We all want what's best for you. We want you to be happy. We want you to be healthy. This is the next step in getting there. Now, let's talk a little bit about legal and ethical issues. This is going to be something that touches us whether we're doing assessment or whether we're seeing the person clinically on an ongoing basis. First of all, we want to make sure that we're assessing correctly, because if we assess incorrectly and harm results, then we're liable. We want to ensure safety. So if we assess correctly, we say that this person is at high risk, but we don't ensure safety and something happens, we are very much at risk and we are very much at risk legally. We are liable for that. We need to know our state laws, and laws do differ by states. So wherever you're practicing, know what your state law is. Document, document. I can't say it enough. Document thoroughly. You can't really go back and document things. You need to document them when it happens, or the first opportunity that you get the chance to document it. Make sure that we're following HIPAA, so we're not breaking confidentiality if we cannot do that, and that we are breaking confidentiality if we are expected to do that, regardless of whether the client is in agreement with it or not. Okay, so documenting, if we're doing this as an assessment, then we're going to document all of the following: the fact that we had informed consent for the assessment, all the biopsychosocial information, our formulation of risk with our rationale, any treatment services that are planned, which would be our recommendations for care if care is needed or appropriate, management, and we should only have to include that if the assessment was suspended because the client needed an immediate link for suicidal care. Any interaction that we have with our colleagues, and by that we mean consultation. If you have a client who's high risk, but they're not acutely suicidal, then that's one of those, man, I'm going to need to consult with somebody. If you have a client who is at moderate, sort of leaning toward high, those are the worst ones, in my opinion, to have to make a clinical call on, because there's a lot of risk there, but there's not enough risk for us to be in the legal zone of, I'm going to breach confidentiality regardless, because legally I can do that to keep you safe. So we have a lot of responsibility and a lot of risk, but we don't have enough to breach confidentiality or force the person to go to the hospital. In that case, consult with a colleague. Do so before you allow the client to leave. While the person is there, get somebody on the phone, get somebody in their office, pull them aside, go through your risk formulation with another clinician who's experienced in suicide risk assessment, and at least the two of you put your heads together to come up with what needs to happen next. And then make sure that you document that. Because if this person does end up engaging in self harm, if they die, you want to make sure that you have done a thorough assessment and that it wasn't just your clinical judgment, that there was two licensed individuals with experience and expertise in suicide assessment who were in agreement that there was not enough risk to force the person to be hospitalized, but that there was um, some very concerning levels of risk. So, progress and outcomes. So, progress, if you're the assessor, you're not likely to talk about progress because you're not going to see this person on an ongoing basis. However, outcome might apply if you had to suspend the assessment and then you later had to meet with the person again, or you suspend the assessment and an immediate referral was made. So you make arrangements for the person to go to the hospital. You send some documentation to the hospital with them, and the hospital does not keep that person. They say, nope, this person, you might think that they're high acute risk, but we don't think so. And they let them go home on their merry way. So you want to make sure that you're documenting what the outcome of that referral was, and then pick up with your assessment at a later rescheduled time and date. Okay, so in therapy and assessment, you might need to do these things. Well, actually, you do need to do these things. So you want to make sure that you're doing really good documentation because it is the primary source of malpractice prevention. Document, document, document. Can't say it enough. You can't have good documentation if you did not do a good assessment or you did not provide good clinical care. However, you can do a bang up assessment. You can be a great clinician. You can give great clinical care and you can still have very poor documentation. So don't be that person. We want good assessment, we want good clinical care, and we want good documentation. So if you don't have good documentation, no matter how good the care was, that can provoke litigation or it can mean the difference between winning litigation and losing litigation. So if we have poor documentation skills, we either don't document or we document poorly. Documentation is a skill like anything else. It can be learned. So if you're not good at it, then focus some of your effort in this area. Get with somebody who does have good documentation skills and have them critique your documentation and tell you what you need to add, how you need to say it, and so forth and so on until you get better at it. So the first legal purpose of documentation is to keep us out of court. So if we are documenting well, then we're probably not going to be in court. The second legal purpose of documentation is if we get called to court, then we have good documentation to defend ourselves. Now, there are other reasons for documentation, but notice I'm emphasizing this is the legal purposes of documentation. Okay, so if we're seeing a person in therapy who's suicidal, then the focus or emphasis changes. So this is not if we're assessing them. If we are seeing them in therapy, then this applies. And you guys can read this on your own because we're going to focus more on assessment. So let's talk about a tear-off warning. So those of you who know of duty to warn, this is a tear-off warning. So if we, in our assessment process, become to actually believe or be able to predict that a patient poses a serious risk to an identifiable victim, then we need to warn that potential victim. Warning a person who's near the person, such as their spouse, or telling the police in their jurisdiction is not enough. We have to actually warn the intended or identified potential victim. So if we have to go down the road of um, homicide assessment, this can very clearly come into play. So we do homicide assessment if we determine that is clinically appropriate. A forensic evaluation, generally there is some specific training for forensic evaluation. That is an evaluation that is offered, referred, or requested by the court, whether it's for maybe is the person competent to stand trial? Was the person, um, were they sane at the time that they committed an offense? That takes specific training, and it is not the same thing as a homicide assessment. Okay, these are the references. If you have an interest in gaining more information in regard to any of the sources that was used um, in this particular lecture. Thank you.